Hello, everyone. For my presentation, I will be speaking about depression and the importance of incorporating community health into mental health issues. We will be discussing a bit about the background of depression, signs and symptoms, diagnosis, high-risk groups, prevention strategies, and case management. Depression is the most common psychiatric disorder in the general population and the most common mental health condition in patients seen in primary care. Although symptoms of depression are prevalent among primary care patients, few patients actually discuss these symptoms directly with their primary care clinicians. Instead, 2/3 of primary care patients with depression present with somatic symptoms like headache, back problems, or chronic pain, making detection of depression more difficult for the doctor. As well, the prevalence of adolescent and adult depression is unfortunately increasing in the United States, and of the subtypes of depression, the two most prevalent are major depressive disorder and persistent depressive disorder, or dysthymia. Depressive symptoms can include depressed mood, loss of interest or pleasure in most or all activities, insomnia or hyperinsomnia, change in appetite or weight, psychomotor retardation or agitation, low energy, poor concentration, thoughts of worthlessness or guilt, and recurrent thoughts about suicide or death. Major depressive disorder is diagnosed in patients who have suffered at least one major depressive episode. An episode is a period lasting at least 2 weeks with 5 or more of the following symptoms, as I've discussed, whereas persistent depressive disorder, or dysthymia, is diagnosed in patients with depressed mood for at least 2 years that is accompanied by at least 2 of the following symptoms, such as decreased or increased appetite, insomnia or hypersomnia, low energy, poor self-esteem, poor concentration, and hopelessness. The term recovery is used to indicate the resolution of a depressive episode, and according to some studies, is defined as at least 2 consecutive months with no more than 1 or 2 mild symptoms of depression and no impairment of psychosocial functioning. Risk factors for depression are multifactorial, including genetic, medical, environmental, and social determinants. An individual is at a higher risk for depression if one or more of the following is present, such as a prior depressive episode, family history, childbirth, which can lead to postpartum depression, childhood trauma, stressful life events, poor social support, or a serious medical illness. Depression is often difficult to detect since patients often present with a variety of somatic symptoms, like, as I've discussed before, such as fatigue, myalgia, slow thinking, difficulty concentrating, or chronic pain. As well, they may be reluctant to acknowledge symptoms of depression to their primary care provider or doctor. A thorough, complete history must be gathered from the patient along with screening surveys like PHQ-9. The PHQ-9 is somewhat more accurate than other screens due to a sensitivity and specificity of 88%, and it is also useful for monitoring a patient's response to treatment. The PHQ-9 is scored from 0 to 27, with scores greater than 10 indicating a possible depressive disorder. It also includes a question to assess whether depressive symptoms are impairing functioning, which is a key criterion to establish a DSM-based diagnosis of depression. Similar to other screening questionnaires, the PHQ-9 is not sufficiently accurate to establish a definitive diagnosis for depression, but scores exceeding the threshold of a positive screen should prompt a careful diagnostic assessment. Diagnosis of MDD is associated with impairment, psych and substance abuse disorders, mortality, disease, and economic burden. Because of this, it is imperative to approach the subject to the patient in a very gentle and empathetic manner, but also partnering with the patient to ensure that they aren't going through this phase alone. There are various risks to developing depression. Some of the high-risk groups, as I've mentioned, are pregnant patients with postpartum depression, military veterans who may present with depression in addition to post-traumatic stress disorder, those who have a family history of depression, patients with alcohol or drug use disorder, male gender, those who are of the white race or ethnicity, if they have a single marital status or are unemployed, if they've had prior psychiatric hospitalizations or are chronically ill or in poor physical health. There are various ways to prevent the onset of depression or to lessen the effects of depression on one's life. One such way is to decrease life or occupational stressors. If someone you know or love is suffering from depression, it's imperative to improve their self-esteem and to provide support whenever they need. Adequate sleep and nutrition, exercising regularly, and reaching out to family and friends are very significant, as well as regular checkups to a primary care physician can lead to an overall fulfilled way of life and a positive outlook that can gradually improve mood symptoms. Psychotherapy, along with antidepressants, are the mainstay for depression. Cognitive behavioral therapy is the most widely studied option and is frequently more available than the other psychotherapies. However, reasonable alternatives to cognitive behavioral therapy include behavioral activation, interpersonal psychotherapy, and problem-solving therapy. SSRIs are generally the first-line treatment based on their efficacy and tolerability. SSRIs are the most widely prescribed class of antidepressants. Reasonable alternatives to SSRIs include serotonin norepinephrine reuptake inhibitors, atypical antidepressants, and serotonin modulators. Tricyclic antidepressants and monoamine oxidase inhibitors are typically not used as initial treatment because of concerns about safety, particularly in overdose, dietary restrictions, and adverse effects. Although sertraline is one of the most widely prescribed SSRIs, and there is evidence that suggests that escitalopram and sertraline provide the best combination of efficacy and acceptability among patients. Most depressed patients who are treated with antidepressants require continuation treatment, and beyond that, maintenance treatment may be indicated as well. Given the lack of superiority or clear superiority in efficacy among antidepressants, selecting a drug is based upon factors such as safety, side effect profile, specific depressive symptoms, comorbid illnesses, concurrent medication and potential drug-drug interactions, ease of use such as the frequency of administration or mode of administration, patient preference or expectation, and cost. All of these factors need to be considered when a physician or a public health official is looking to see how to best maximize the compliance of the patient with these medications. As an example, bupropion is useful for patients who prefer to avoid sexual dysfunction or want treatment for tobacco dependence, whereas escitalopram or citalopram may be less likely to cause drug-drug interactions. For patients who want to avoid weight gain, mirtazapine may be the best choice for them. Patient response to antidepressants during prior episodes and family history to response to antidepressants are often used in choosing an antidepressant. However, clinicians may also bear in mind that there are other non-specific factors such as conveying empathy, establishing rapport, developing a therapeutic alliance and sense of collaboration, and instilling hope in the patient may affect outcomes as much as the choice of antidepressant that the patient is placed on. Thank you so much for your time.